Well, good evening, everybody. Thanks for joining us. Delighted that you're able to be here for what is our ninth collaborative public and patient involvement event from Derm Academy at St John's with the National Eczema Society. So this webinar this evening is going to focus on hand eczema. So I look at the disease overview from our first speaker and then second speaker to tell us a little bit about how we should be managing it. So what we'll do is we'll have our two speakers and then we're going to have a question and answer panel where we're going to be joined by a further expert panel member with questions that you can submit from the audience. Before we get started, just a few housekeeping points. Please do not video or audio record or take photos of any part of this event this evening. You'll be able to see and hear the panelists and the presenters, but we can't see or hear you. If you'd like to ask a question at the end, you'll see at the bottom of your Zoom bar, there's a little Q&A button, and that's the one to use. The chat function is not working, so that's the Q&A button if you've got any questions you'd like to ask. And if you feel shy and want to be anonymous, that's absolutely fine. After the event, we'll be sending you an email so you can provide some in-depth feedback for us. That's really helpful, helps us improve our offering and make sure we're tackling issues that you're interested in and want to hear more about. And also, if you'd like to make a donation to the National Eczema Society, there will be details at the end for how you can do that with a QR code. So why don't we get started with our first speaker? And our first speaker is Dr. Felicity Ferguson. So she did her dermatology training in Manchester before coming to St John's, where she undertook a clinical fellowship in cutaneous allergy. She's a really tip-top expert in eczema, particularly with an interest in occupational dermatology and severe eczema. So I'm going to hand over to you, Felicity. Thank you.
Right, thank you so much, Gemma, for that kind introduction, and thank you very much to the National Eczema Society for having me. I was really pleased that we're shining a spotlight on this really difficult disease. So I am going to take us through chronic hand eczema over the next 20 minutes. Here are my disclosures. So firstly, what is hand eczema and what do we know about what causes it? And then I'm going to focus in on one of my areas of interest, so patch testing in chronic hand eczema. So looking at allergic contact dermatitis, when is it relevant? What do we need to think about when considering this? So firstly, hand eczema is a painful, itchy, inflammatory and heterogeneous skin disease affecting the hands and or the wrists. Heterogeneous meaning it can look very different in different individuals and it can be caused by lots of different things, and we're going to talk through that this evening. For it to be chronic, it needs to last for longer than 3 months or relapse 2 or more times per year. So hand eczema can look very different in different people. We often see a lot of redness, a lot of inflammation with this condition. In skin of colour, this may be more purple, it may be brownish, purple, or even grey. Patients may get a lot of scaling with their hand eczema or hyperkeratosis, so thickening and scaling of the skin, like in this bottom left-hand photo. Some people have vesicular hand eczema, also known as pompholyx more commonly. So people get small fluid-filled blisters appearing often on the palms of the hands or on the fingers. These are really itchy. They can join up to be larger blisters. We see lichenification, so people get thickening of the skin in response to being so itchy they've been rubbing and scratching at the skin. We see splits and fissuring of the skin. We see a lot of swelling, particularly when it's acutely inflamed and people are flaring. And if you have hand eczema around the base of your nails, you may develop a nail dystrophy, so your nails may grow through abnormally, so with pits and lines like in that photo there. And what's going on? What puts you at risk of getting chronic hand eczema? So we broadly divide it into internal risk factors and external risk factors. So thinking about internal, this is how we're really made. So it's your natural skin barrier, how well that's working to protect you from the environment. And if you have atopic eczema, you are at increased risk of getting a chronic hand eczema. Then when thinking outside of the body, irritant contact dermatitis, so exposure to irritants is a really big driver in chronic hand eczema. So that may be frequent hand washing, that may be exposure to soaps and detergents. If you work in a very physical or mechanical job, that stress again can damage your skin barrier and put you at risk of developing chronic hand eczema. We see hand eczema more commonly in certain occupations. So we've got them listed here: cleaners, healthcare workers, hairdressers, beauticians, construction workers. In some patients with chronic hand eczema, we see contact allergy. So this is allergy to chemicals in the environment. And the main ones we think about in hand eczema are the rubber chemicals, preservatives, fragrances, and metals. And we will talk about those in a short while. To a lesser degree, some people may find atopy allergens, like allergies to grasses, pollens, may play a role in their hand eczema. Now, I appreciate this is a busy slide, but the main reason I've included it here is to show you how our understanding of chronic hand eczema is evolving. And essentially, it's a very complicated condition, and there's a lot of overlap between different subtypes. This latest characterization is from the 2022 European Society, and it's the most up-to-date version that we've got. You can see broadly they're asking us to define what we think is causing hand eczema and how the hand eczema looks on the skin. The key message is that when we look at patients with hand eczema, it's in more than half of patients, they have more than one thing going on. So it's not uncommon in clinic for me to see somebody with an atopic hand eczema and they may have an irritant contact dermatitis. For example, if they've got a young baby at home and they're washing out their hands a lot, or if they're a cleaner or they work in healthcare, for example. And again, we may see people who get the blistering flare-ups of their hand eczema, but other times may have more of a dry fissured picture with involvement of the palps of the fingers, so the tips of the fingers. I think one of the important messages is that atopic hand eczema is only one of these subtypes. So, it's not a prerequisite to get hand eczema. You may not have any atopic background and you may develop a hand eczema. Hand eczema is a really common condition, and that is why it's really important that we are seeing movement in terms of our treatment options, which I know Rick is going to be speaking about with you in a short while. When we look at how common it is, the 1-year prevalence rate is around 9%. So this is a European study, but if you think about everyone in the UK, if you followed them for a year, 1 in 10 of them pretty much are going to have an episode of hand eczema. So it's really, really common. It can happen more in women, but we see it both in men and women. Definitely a history of childhood eczema, so background atopy is a risk factor, and we see it in around 60% of cases. The big thing about hand eczema is there's a real risk that you're going to go into long-term or chronic disease. That's why it's really important that we manage it aggressively. And the other point is that for a lot of the conditions that we treat, most people have mild forms of the disease, and then we see a significant minority with moderate to severe disease. Hand eczema is different. Almost a half of patients have moderate disease, and nearly a quarter have severe. So the majority have got difficult disease. And we use our hands for everything. They're hugely visible, and hand eczema has a huge emotional impact. People do not like how their hands look. They are very self-conscious. They are very embarrassed. And hands, of course, we're involved in everything. It really places a limit on what people are able to do. So people become very frustrated for the appearance of their hands, what they're able to do with their hands, for the issues around treatment, because we really ask you to completely change your routine, to support your skin barrier function, to apply lots of creams. And that can be really difficult and places a large strain on people. I also hear it in the sense that people often have difficulty in their personal relationships at home. They're really upset. They can't contribute the way they would like to family life, all the things their hands hold them back from doing. And when we think about work, hands, of course, have a huge impact on people's ability to work. This study looked at people who had hand eczema that wasn't responding to strong topical steroids. And over a year, a third of them reported time off work due to the severity of their hand eczema. And the average amount of sick leave was 7.2 days. And this doesn't even take into account all the modification that people with hand eczema have to do in the workplace to manage to work at all. So it's a really important issue that we really need to be tackling. And then Coming on from that, I now want to bring in allergic contact dermatitis. So this is really important in hand eczema because we see it pretty frequently. So around 1 in 4 of the patients with hand eczema that I see will have a relevant contact allergy that's playing a role or maybe even completely driving their hand eczema. And if you have pompholyx or vesicular hand eczema, so the blistering form, around 1 in 3 patients will have a contact allergy involved in their disease. And we do see it in certain occupations where you're going to be at higher risk of picking up allergy to certain things. But equally, it's very important that we pay attention to personal life exposures as well, exposures in the home. We know that allergic contact dermatitis in hand eczema is associated with poorer quality of life compared to people with hand eczema without contact allergy. And I think that's likely because if we don't identify it and we don't avoid it, it's going to be very difficult to treat that hand eczema effectively. So how do we look for it? We do patch testing. And there's an image there on the top right, a lady with her patches applied. So we stick on small samples of different allergens. So rubber, metals, leather, we've talked about those, fragrances, preservatives, lots of other things. And they're stuck for 2 days. And then we read the skin. So we look to see whether people have had a reaction like an acute eczema effectively at day 2, 4, and then at day 7 here at Guy's in London. And you can see an example of what a positive reaction may look like at that bottom image. So let's talk about contact allergy in chronic hand eczema. There are, of course, lots of different allergens that we see, but these are the key groups that we worry about in hands particularly. And I'm throwing in nail cosmetics because we're seeing far more of this issue than we ever have before. And I think it's because of patterns of usage. So firstly, metals. So we see nickel, which is a metal found in costume jewelry, metal parts of clothing, a lot in patch testing. It's the most common allergen, but most people usually know about it. They've had a problem with earrings, they don't wear them anymore. However, it's one not to miss with hands. I get a few cases a year, particularly of people working in jobs where they're handling a lot of keys throughout the day, particularly nurses opening drug cupboards and so on. If you've got fingertip involvement and you're handling a lot of keys, you may want to think about whether nickel's an issue for you. And hot off the press, this was a patient I had his last visit with me just yesterday. 34-year-old science teacher, 2-year history of chronic hand eczema. He had a pretty strong atopic background, so you may be forgiven for assuming his hand eczema was all atopic hand eczema. But we patch tested him, and you can see how nasty his hand eczema is at baseline. He really had vesicular flare-ups leading to sort of splitting and fissuring of the hands. On patch testing, he had strong positive reactions to nickel and cobalt. You'll have to forgive me for the patient image. I missed taking it when he was with me, and he kindly sent this in for us to see today. And we then explored where this could be coming from, if it could be relevant. So he was already quite suspicious of his vape because he'd stopped using his current one and changed it for a different one a couple of months ago, and his hands had got a bit better. We even tested his vape liquid, but that was negative. And he brought in his old vape case, and the plastic has worn through around the edge. There's a special test you can do to see if there's nickel release from objects, and you can see it here. There's a little pink on the top of this Q-tip, and around that base of that vape, around where he hasn't taped it up, there was significant nickel release. And just to convince you further, his hand started with eczema to the base of his right hand, where he was holding the vape on that little and ring finger before spreading up over the whole right hand, and then spreading a bit to the left as well. So I really feel this is nickel contact allergy from his vape that caused his hand eczema. So I'll be following up to make sure he gets completely better. Rubber. So rubber gloves, really important one not to miss in chronic hand eczema. If you have hand eczema, you will know that we are recommending that you wear gloves to protect your hands from all wet work. And that is good advice for the vast majority. But some people are at risk of developing rubber accelerator allergy. So rubber is taken from trees, and we add chemicals to it to give it useful properties. And it's these chemicals that can cause allergy. Sometimes it's really obvious. If you have confluent hand eczema, so hand eczema completely covering your hand with a lovely cut off at the wrist where the glove stops, that's a good sign that we should be worrying about your glove usage. Other times it is more subtle, it can be patchy. This sketch, all the way back from 1960, still has relevance to me in clinic today. If I see a patient with eczema affecting the base of their palm, at the bottom of their thumb, and the base of their fingers, I would always worry about rubber glove contact allergy. And that was the case for this gentleman on the left. This is a more patchy diffuse hand eczema, and they had rubber glove contact allergy, shown here in these photos. So again, another one not to miss. Where do we worry about it? We most worry about it in healthcare workers and dentists. And there was a US-based study that found it was relevant in a quarter of all healthcare workers, compared to around 7% of non-healthcare workers. If you have it at home, you can swap to plastic or vinyl gloves. In the workplace, generally, you do need a rubber glove, and you can get rubber accelerator-free gloves through your occupational health. Fragrance is another important one in hand eczema. If you have hand eczema, I would do your best to avoid fragrances coming into contact with your hands. We're very tuned in dermatology about fragrance around the face, particularly around the eyes. But in hands, it's relevant around 10%. So that is a good number. And it's not just the fragrance that you may spray on your skin before you leave the house. I'm thinking about fragrances that are added to all of the products we come into contact with. So hand creams, hand soaps, your household cleaning chemicals, for example. All of those will be fragranced, and all of those may be contributing to your hand eczema. Preservatives. So this group of preservatives has a really unfriendly name, the isothiazolinones. I'm mentioning it here because it's really important in hand eczema. So this Danish study found that if you had isothiazolone, I can't say it now myself, isothiazolone contact allergy, hands were the most frequently affected site. And when they looked to see where, household products. We now have a wait of a year for patch testing in London, which is really difficult. And so if I see patients in clinic with hand eczema and we're waiting for patch testing, I will recommend that they avoid the isothiazolinones, because it may be a factor in their hand eczema and we don't want to miss it. So that's just one to think about. And then thinking about nail cosmetics. So there are contact allergens in nail varnishes, but we see those very infrequently now. The big thing that we're seeing at the moment is lots of people coming through with methacrylate contact allergy, so HEMA contact allergy. So this is from your gel and acrylic nails. All forms of UV cured nails can be a problem, and your air cured acrylic nails. And we can screen for that testing to HEMA, which is hydroxyethyl methacrylate. So it's one of the methacrylates. And it is the usual allergen. If you're allergic to HEMA, you need to avoid all of the acrylates because there's high rates of cross-reactivity between them. Rates are probably over 3% in most patch test populations, and definitely here with us in London. So why are we seeing so much of it? There's really rising popularity. You will see yourself, lots of people are getting these nails. Another big culprit are the home gel nail kits. So the issue with these, the easy accessibility is going to increase people's usage. So you are going to be more exposed to these chemicals. Non-professional application may be less accurate, so you may be getting some of the polish on the skin around your nails more often. So again, that's going to increase your risk of becoming allergic. And the big one we really worry about is, even though they often say they're professional grade, they probably don't cure the polish well enough. So it's when these nail cosmetics are liquid, that's when they cause problems with allergy. When they're hardened, then they can't cause allergy. So if you're leaving uncured acrylate on your nails, you're increasing your risk of becoming allergic. And I see someone probably every month who's swapped to doing home gel nail kits and then shortly afterwards has started having problems with contact allergy. The other trap to watch out for, which I'm seeing more now, is there's been a lot of popularity around HEMA-free gel polish. And I had a lady recently who was HEMA positive on patch testing. She was happy that she was avoiding HEMA because her nail tech had sourced a HEMA-free gel polish. But she was coming back to me because she was still experiencing hand eczema and she was getting some eyelid eczema as well. And when we got the information around the polish, you can see here hydroxypropyl methacrylate, so very similar, HPMA, very similar to HEMA, and isobornyl methacrylate. And as I've said, there's a lot of cross-reactivity between these chemicals. So HEMA-free gel polish is not a safe alternative. And they are advertising themselves widely online, so do watch out for that, and I'd recommend avoiding. So with that, chronic hand eczema, we know it's got a huge negative impact on quality of life, and most patients have moderate to severe disease. Most people will have more than one thing going on driving their hand eczema, and it's really important that we think about that because that's going to inform how we recommend management and how best we can treat your hand eczema. If you're waiting for patch testing, and even if you've had patch testing, I would still watch out for the isothiazolinone. Avoid them in your household cleaning chemicals. And whatever you do, don't get a home gel nail kit. Thank you.
Brilliant. Well, thank you so much. What a fabulous overview of hand eczema. Really lots of food for thought there, Felicity. That's great. So great pleasure now to introduce one of my other colleagues for the second talk. This is Rick Wolf, who's a consultant dermatologist at St John's. He did his integrated academic training there and also completed his PhD in skin immunobiology at King's College. His keen interest is medical dermatology, but specifically working in the large psoriasis and eczema clinics that we have. And he's also very active in terms of clinical trials. So there could be no one better really to tell us more about how we manage hand eczema and whether there are new treatments that we need to be aware of. Thanks very much, Rick.
Thanks, Gemma. Can I just check you can see my slides?
Yes, we can.
Great. So thanks. So I'm going to take over from Felicity and discuss treatment approaches to chronic hand eczema, but also with a bit of a focus about what's new, because in a reassuring and good way, there's a lot of development in the treatment of eczema and specifically hand eczema. So there's quite a lot that we can do increasingly for this problem, which is clearly common and it can have a big impact on individuals affected by it. So these are my disclosures, sort of paid and unpaid work that I do outside of my clinical work. I think Felicity's really nicely set the scene about chronic hand eczema as a real problem to the individual. You know, the hands are highly exposed from day-to-day activity. They're highly visible sites to the rest of the world. And in our term, in our space, in the dermatology space, to sound a bit medical, but we describe these as high impact sites. So these example photos here show widespread hand eczema, you know, affecting either the whole palm or the whole back of the hand. But sometimes you don't need much hand eczema for it to still have a disproportionate impact on your day-to-day functioning, such as fingertip eczema. And there's actually quite a standardized approach to how we build up the treatments to hand eczema. And so I'm going to talk a bit about the standardized approach and then adding into that some new directions in which we're going. So obviously in the background, when a patient presents with hand eczema, as Felicity alluded to, we need to work up that patient to try and establish what cause of the hand eczema is driving it. Is this an endogenous process, you know, from risk factors within the individual, or are there exogenous external factors which could be contributing or driving the process, whether that's an irritant or allergen? And when we think about helping the individual or things that the individual can do, there's quite a large number of things. And this starts really with quite basic approaches. That's around skin protection, avoiding triggers if they've been identified, whether that's an irritant or allergen, use of regular emollients, and obviously education around this so patients can understand how to approach their hands. And I mentioned skin protection, and this is really about maintaining that barrier component of the skin. So I've touched on emollients, which help restore some barrier function to a degree, but that's also around principles like good hand washing. So that's avoiding excessive frequent hand washing, soap avoidance, the use of soap substitutes, avoiding extremely hot water, which can exacerbate barrier dysfunction, and gentle washing and gentle drying. So not excessively rubbing the hands, which again can cause trauma. When we think about other interventions or sort of medical approaches, again, as Felicity touched on, a large part of the process that's driving chronic hand eczema is inflammation in the skin. So there's too much inflammation in the skin that's contributing further to the breakdown in the barrier, you know, the cracking and fissuring that we see of the skin, and some of the symptoms that the individual experiences. So the itch and pain that may be associated with hand eczema. And still, to this day, a kind of a stalwart of first-line therapies is using simple topical anti-inflammatory treatments. And this will largely be instigated in the community, either through a pharmacist or in primary care, so through your GP. And the types of drugs that we're talking about are topical steroids, which have an anti-inflammatory function. There's one at the top right, betamethasone, or a class of drug called calcineurin inhibitors, of which one of them is protopic, 0.1%. And this is another anti-inflammatory medicine that's not a steroid. And really, if someone has an inadequate response to this, and we can discuss what that may look like in a moment, there are ways that we conventionally escalate treatment. And the red line here is indicating these are treatments that are largely delivered in a more specialist setting with a practitioner with an interest or expertise in dermatology, whether that's a GP with an extended role or actually within a dermatology service, whether it's in the community or in a hospital-based clinic. And if I just go back to the second line, so the kind of things that we're thinking about escalating patients to are types of phototherapy, where we use localized light treatment to the hands as an anti-inflammatory treatment, or certain medications, one of which is called alitretinoin, which reduces the scaliness associated with hand eczema. And if this doesn't work, we think about other drugs which reduce the inflammation in the skin, but these are systemic medicines. But when we think, well, what's new? And so the areas that I'm just going to touch on are that there's been fairly recent development around novel or new topical treatments. So that's creams, so skin-directed therapy. And when we think about those patients where skin-directed therapy is not good enough and we're having to progress to medicines, there's actually been quite a lot of development around the way we treat eczema and atopic hand eczema within that. And there's data coming through about how effective some of these new medications can be. So the sort of big new area when it comes to sort of cream or topical based treatment for hand eczema is a cream called delgocitinib. That's the medicine. The brand name is Anzupogo. And this medicine was just approved for reimbursement in the NHS at the end of last year. So that went through a process called NICE approval. And this is for patients with what's been defined as moderate to severe hand eczema. And this is positioned after having had a trial of topical steroid, but where you've got inadequate control. And this is a simple intervention. It's a medicated cream. It contains a medicine called delgocitinib, which is what's called a JAK inhibitor, but that's just the way in which the medicine calms down the inflammation in the skin. And the simple instructions with this cream is that you're applying it to affected areas twice a day, every day, until the skin is clear or almost clear. And because this medicine's new and relatively expensive, the ask of us as the clinicians prescribing the medicine is that we reassess the patient after 3 months of use. And if the patient's not had adequate response, we would discontinue because we would think about other options. And actually, what adequate response with is not well defined. And actually, within the medical community, in the dermatology community, there's quite a lot of discussion about how you consistently approach this. But the broad concepts is usually it's a joined up decision between the prescriber, the clinician, and the patient. And so, we as the prescriber are looking at the hands and we're looking for evidence of objective improvement. So you might have a patient that starts off with severe hand eczema, and by week 12, it's improved. So we're seeing it as being, for example, mild, or if they've had a really good response, it's already clear or nearly clear. And the patient themselves are reporting some qualitative benefit whether it comes to how they're able to use their hands in a positive way that they weren't before treatment, or some of the symptom relief that they're getting from the treatment, such as reduced pain or itch associated with their chronic hand eczema. And just to show you as doctors, we look at standardized outcomes when it comes to looking at these new treatments and how people like the NHS approve these as effective or safe treatments. And to give you a flavor of what the clinical trial data looks like for a treatment like this. So these two graphs refer to two parallel studies that were done looking at the effectiveness of delgocitinib cream compared to the placebo vehicle control. So that's the same cream, but without the added medicine. And these patients are applying the medicine every day, twice a day to the affected areas on their hands. And using quite a hard measure of having clear or nearly clear skin, you can see about a third of patients are achieving that with the medicated cream after 4 months, so 16 weeks of treatment, but most of the benefit being over the first 2 months. And again, a slightly different way that we as dermatologists look at outcome, but the bottom graphs here are showing patients that have achieved a 75% improvement in their hand eczema. And you can see with this slightly lower threshold, so these patients are not necessarily achieving clear or nearly clear skin, but they're 75% better from where they started. You can see that around half the patients in this cohort are achieving that. So for us, this is, exciting, promising new direction because it's giving us a different mode of action for a topical treatment. And these are just examples through the sponsor, but at Guy's Hospital here in London, we've been involved in several of the studies regarding the use of this treatment. And I would say, our experience reflected that I've just presented and these images. But you can see on the left-hand side, someone with really quite marked, widespread, severe hand eczema affecting the back of their hand. And on the right-hand side, it's mostly healed and they have some sort of faint erythema or redness affecting the back of the hand. This is the palm of the hand, a different patient. Again, severe widespread disease, some cracking or fissuring on the central palm, some scale or what we term hyperkeratosis. And then this patient's had a really good response. You can see that after 4 months of twice daily treatment, their hand is clear. And going back to the wording, so this patient would then stop treatment and you basically retreat if you get an early relapse. So in the long term, you then treat as needed. And then moving beyond, so if topical treatments, that's creams, ointments, potentially phototherapy, if they're not, so skin-directed treatments, if they're not working, we then think about medication. So this is appreciating that we need to use a slightly stronger treatment that's affecting the immune system from within to try and calm down the inflammation in the hands. And this may also be because the individual's got atopic hand eczema, so they've got atopic eczema or atopic dermatitis affecting other bits of the body. And historically, we did have medicines that we were using for this. But quite recently, since around 2018, there's been a big change in how we treat moderate to severe atopic dermatitis with drugs. There's a lot of interest. This is a big problem in society. It's a common disorder. It has a high burden on the individuals. And increasingly, we've worked out ways in which we can, in quite a focused way, reduce the inflammation in the skin that's driving atopic eczema. And so this is a list of drugs, 7 recent medicines that have also all been approved for use within the NHS for the treatment of moderate to severe atopic dermatitis in adults. But what's good for individuals with hand eczema is the manufacturers of these medicines are appreciating that this is a subgroup of patients where with this high impact site disease, it has a disproportionate impact on their quality of life. And so they're trying to get better understanding just about how effective these kind of treatments may be. So I'm going to show you 2 recent sort of data sets around 2 of these medicines. So dupilumab or Dupixent is a commonly used new injection for the treatment of atopic dermatitis. And this is, again, the top right figure is looking at those patients that achieve clear or nearly clear skin. And you can see about 40%, so 4 out of 10 patients are achieving that over the first 4 months of treatment. And Felicity mentioned about the symptoms and the burden of symptoms that individuals experience with chronic hand eczema, and itch being one of those. And one way we measure itch is we get patients to score it out of 10. And so, for example, they might say their itch is 8. And it's considered that if someone has at least a 4-point improvement, so that would be a reduction from 8 to 4 or better, that's considered, meaningful, impactful for the individual. And so this score on the bottom right is showing the number of patients that have at least a 4-point improvement in itch. And you can see about half those patients treated are achieving such an improvement. This drug, tralokinumab or Adtralza, another injection-based drug that's fairly new. It's been approved in the last 4 or 5 years for the treatment of atopic dermatitis. But again, the manufacturers of this medicine have done studies specifically in chronic hand eczema in atopic individuals, a very standard design where you're comparing the treatment with dummy injections, so a placebo, and pretty similar actually to the previous drug. They're showing around 4 out of 10 patients are achieving clear or nearly clear skin, and about half those patients are achieving at least a 4-point improvement in itch, and also at the bottom there, at least a 4-point improvement in skin pain. So this is showing that, not only do we see objective improvements with all of these treatments, but, the investigators are interested in what symptoms patients experience, and we see simultaneous improvement in the symptoms that patients are reporting. So to pull it together, so going back to what a revised kind of ladder or treatment pathway starting to look like for individuals with chronic hand eczema, I think the key takeaways here is there's a lot that can be done. So to be reassured, whether that's sort of what one may term sort of simple interventions that individuals can do themselves, measures that they can access through primary care or the community, and if those are failing, interventions that you can access through more specialist services. And I think what's great looking at this consensus piece from 2024 is that now these new treatments are also working their way in. We've got different topical creams that we can be using that have anti-inflammatory mode of action. And then also when it comes to medicines, we're getting increasingly specific medicines that have better outcomes for patients. So that's where I'm going to conclude. And I think hopefully we've then got the opportunity to have a panel discussion to discuss these topics and any questions that you may be raising.
Brilliant. Thank you so much, Rick. That was really lovely and clear, and how good it is to see your timeline of all these newer treatments that are available to us. For so many years where all we had was topical steroids, but it's great to have all these options available now for people with difficult, very impactful hand eczema. So brilliant. Gives me great pleasure to introduce the third member of our panel. Along with Felicity and Rick, we're going to have Julie van Onselen. And she's a bit of a polymath because she spends a day a week as clinical advisor for the National Eczema Society, which is wonderful. And when she's not doing that, she spends a lot of time as a clinical nurse specialist in dermatology in primary care. But she also does lots of editorial work, lots of writing. So really great sources of information to people who are living with eczema. So what I'd like to do is to open up the discussion, and thank you to everybody who's been sending in your questions. I'm going to try and go through these now and see if we can get some answers. So delbicitinib, is that something you can prescribe for children? Who wants to take that one? Rick, is this a good one for you?
Yeah, so not yet, but there are pediatric studies coming through. So it's highly likely. So at the moment, the license is from 18 onwards, but it's highly likely that in the near future, it will start likely with adolescents, but it will come through. And also, there are other JAK inhibitor creams that are also coming through, which may be more broadly for the treatment of atopic dermatitis, not just hand eczema. And again, there may be some variance in the age with which you can use those treatments.
Great. So we'll watch this space. And if someone has severe hand eczema, is this something that they could just go to their GP and ask to have prescribed, or is it something they would need to get from a specialist?
So at the moment, and the way this medicine's been approved by NICE, it's for initiation in a specialist dermatology setting. And there's some variation around the country, whether that would be in a community service where you have dermatologists working or GPs with a specific interest in dermatology, or whether that would be in a hospital-based clinic. But at the moment, this treatment would not be initiated by a GP. But there's a lot of pressure to keep patients out of hospital clinics and in the community. And so with time, it may be that either care is stepped down to the GP so the GP can continue treatment, or GPs will build confidence and they'll start prescribing, but not at the moment.
Okay, understood. And other side effects, keeping with the delcasitinib, what are the things that people might expect with using this for hand eczema?
Should we let Felicity? So Felicity's also got experience with the treatment.
Yeah,
So
that would be great,
yeah.
Felicity.
So I'll let Felicity come in on that.
Sure. So from the clinical trials, it was a very well tolerated topical treatment. And there were no serious adverse events noted at all during the 1 year long-term extension. So we haven't got data beyond the year, but it all very reassuring up to then. There was a 1% reported rate of application site reactions. We don't really know what that means, whether that was a flare of dermatitis or reaction locally to the cream, but that is recognised. The good thing is there's no or minimal systemic absorptions. There's no need for lab monitoring, no need for blood tests. You can just apply it to your hands and move on.
Brilliant. Thanks, Felicity. I'm going to go to Julie because one of the things that hand eczema often gives you, as we've heard about, is those fissures. We've had a question about what is the best way to manage those very painful fissures that people get with hand eczema.
Yes, thank you, Gemma. And I'd absolutely agree. It's one of the most painful things about hand eczema when you have fissures, which are actually cracks in the skin that can actually be quite deep, painful cracks. They can also be a portal for infection. So I think, first of all, actually, everything we've discussed, the protecting, the frequent moisturising to repair the skin barrier. But if you've actually got deep cracks and fissures, it's quite useful to give them some extra protection. So there are various things you can use. Again, you would only really be using these things if the hands were not infected, I must say, because you wouldn't want to cover if hands were infected. I personally favour Duoderm, which is I mentioned the brand because it's the only one there, which is a very thin hydrocolloid dressing. It is particularly useful because you can actually wash or shower with it, so it's very protective. But there are other. You can actually, if you're using steroids, you can actually use steroid impregnated tapes as well. So fluoro oxycortide, which is a moderately potent steroid, or the Betacil plasters, which you can wrap around, which actually is a potent steroid. So I think, managing and trying to heal the cracks alongside the other treatment is really important because they really do cause a lot of pain and distress.
Brilliant. Thank you very much, Julie. I think this one's probably best for Felicity. How do you differentiate between atopic dermatitis on the hands and whether there might be an allergy or an element of irritant dermatitis?
So just looking at the hands, it can be very difficult to pull it apart. So that's where history is so important. So what the patient can tell us in terms of whether they have a background of atopic eczema as a child, do they have hay fever symptoms, or have they had that in the past, that sort of thing. It's also asking questions around exposures. So is there frequent hand washing in the home or in the workplace that might be playing a role, and we'll address that. And then from a contact allergy perspective, we obviously have suspicion based on if you've noticed flaring after certain things, but that isn't always present, particularly in chronic hand eczema. So then it'll be down to needing to move forward to patch testing, because that really is the only way we'll be able to tell for sure one way or the other. So if you have moderate to severe hand eczema and you're not adequately controlled with topical steroids and appropriate hand care, we should be thinking about patch testing you.
Brilliant. Thank you very much for that. Rick, we've had a question asking where can somebody get more information about different treatments for hand eczema, and particularly when people have got a combination of hand eczema and foot eczema, where would the best sources of information be?
Yeah, so I mean, well, we can brainstorm it across the panel, but the BAD, so the British Association of Dermatologists, has a lot of patient-facing resources, both about skin conditions, including eczema, chronic hand eczema, and also about specific treatments. So there are drug-specific information leaflets. Also, the manufacturers themselves have patient-facing patient information leaflets that are either available. You'll find websites for products, or there's the EMC website where you can find, where companies are mandated to upload patient-facing materials. The National Eczema Society also has resources. I'll let Julie discuss what specific hand eczema resources they may or may not have. I don't know if there are other places, Felicity, that you would signpost people to.
No, I signpost the BAD, and there's a good how to care for your hands sort of the information leaflet. Some of that will be, everyone knows, but there are some details in there that can be useful in supporting ongoing management of your hands. And then for more detailed information, again, BAD and I think the National Eczema Society. So I don't know if Julie wants to raise the flag for the NES.
Yes, I can add to that. We have a wide range of fact sheets and also booklets, as well as our website. So we have a fact sheet on hand eczema, which gives you lots of practical tips and covers actually everything you talked about tonight. But for people with a foot eczema, we also have a fact sheet on a type of eczema called Pomflix eczema, which covers feet as well. So this is when you have a more difficult form of hand eczema. I think we discussed it before, where you get small sort of vesicles and blisters, and that can be very itchy and quite weepy. So we discuss that along with foot management as well. And then we also have a really useful booklet on contact dermatitis and patch testing. So that's really, really useful because it sort of explains what contact dermatitis is, what irritant allergic dermatitis is, and tells you, what happens when you go for patch testing. I think also the health safety executive website is quite useful because that gives more advice on managing hand dermatitis at work as well, and what the employers should be putting into place as well. So that's another useful resource. I think there's lots out there for you.
Brilliant. Thank you. Great panel response. Very broad. That's great. Is there any advice about the management of hand eczema in sun-damaged areas, thinking particularly about the backs of the hands? Is there special consideration? I don't know if Rick wants
I'll
to
make a
take that.
brief comment. Not really. I think one thing you need to step back from is check that is it just, well, I say just, but is it primarily inflammation, or there are other skin changes that we see related to sun damage that won't behave like hand eczema. So you can treat things, as we've discussed, all these measures around skin protection, skin barrier repair, anti-inflammatory treatments, whether that's topical or systemic. But if you're still having persistent problems, it could also be that there's something else going on, that you've got what we call actinic, so sun-related damage. So that may need some input from your GP or a specialist.
Okay, thanks very much. And going to the opposite age spectrum, we've got a question about somebody whose child, 5-year-old, has a lot of hand eczema when doing sports. What's the right thing to do? Maybe this is a good one for you, Julie, with your practical tips. Is it good to just let them carry on and do that sport, or are there particular measures that you might be able to take to avoid the eczema flaring up?
Well, I suppose it does depend on the sport. Where it's a sport where you have to use your hands, as in I'm thinking of netball or hockey, and you're holding something, or whether it's swimming. So it does depend on the sport, but it sounds like there must be some contact with the hands if the hands are flaring in sport. So I think it's really difficult. I think the first thing is if the child's enjoying sport, and no child should be prevented from any sport, and particularly swimming, actually, that's really important. So I think it's just protection, and maybe before child is playing the sport, something I think is quite useful to sometimes do at night is what I call give your hands a bit of a moisture surge. So use maybe a thicker emollient under cotton gloves at night. So sleep with it, so your hands are really well, moisturized, and the barrier is well protected. And of course, there could possibly be a contact element. I mean, some sports, like a hockey stick might even have a rubber handle. So it might be that it's getting worse, and that would be one for Felicity. There may be a contact element as well. And then obviously washing hands well after playing sport if the eczema's flaring, with lots of emollients afterwards. But I would say, keep your child playing their sport, and maybe you might need more investigation. I'm not sure.
Okay, brilliant. Thanks, Julie. Any common contact allergens that you see related to sports exposure, Felicity?
So it depends on the sport. So we see coliformium in things, so people are doing gymnastics, the rock climbers, the chalk that they use, that can often cause problems on the hands. And then, as Julie highlighted, rubber can be a culprit if they're handling rubber balls, rubber equipment, batons, whatever it may be. Children with difficult hand eczema often do have a strong atopic background, and that may well be the key driver for them. But it is important that we do think about contact allergy. And I'm sort of on a bit of a flag for patch testing children at the moment, because once you hit the age of 3, you've got just as much capability of becoming sensitized as an adult. So we should be thinking about it as well if others remain listed. To be honest though, in kids, usually what we see are fragrances, so linalool, limonene fragrances, again from hand creams, things like that they may be coming into contact with. And we also see the isothiazolinones. There was a craze for slime a while ago, and people making it with their washing up liquid. That was a bad idea. But at the moment, we haven't seen too many epidemics in kids, but they're the main ones to think about.
Yeah. And if somebody has developed hand eczema related to fragrances, how often is it that it's also a problem for airborne exposure, or, for example, to preservatives like the isothiazolinones? Is that a big consideration in sort of chemicals used around the house, or if you're walking through Selfridge's perfume department, is that something that might give you problems?
Specifically for the hands, it is going to be less likely a culprit. But sometimes I think the concern is if you're getting lots of micro exposures, there may be enough if you're already in a vulnerable position to tip you into a flare. So we say, do as much as you can without, being a shut-in. You can still go out and enjoy life, but don't hang around in Lush doing all the testing.
Yeah.
I think just very briefly building on that. So this is drifting more into the generalized atopic or eczema patient. There is a pattern that we describe as being exposed site eczema. So that would be someone where the dermatitis may be their hands, but it may also involve their face, their upper neck, maybe a bit more onto their forearms. So these, when you're having a pattern of eczema like that, that's where you then, as a clinician, think, could this be some sort of exposure or contact? And we think patch testing.
And certainly if you have a fragrance contact allergy and that distribution of eczema, it's really important to avoid fragrance as far as you possibly can. And definitely that's where room diffusers, scented candles, car fresheners, all these little things, it's really important to cut out and avoid. But essentially, if you're just buying something over the counter, if you're not specifically looking for it to be fragrance free, you'll almost certainly have fragrance in it. So it's a difficult one. You have to find your products and check every time.
Great, understood. Now, a question I think we probably get asked a lot in clinic for eczema in general, but here let's try and be a bit more specific about hand eczema is, could stress be playing a part? What is the role of stress in exacerbating hand eczema? I'll leave that open for whoever on the panel would like to take that. Maybe you all have a slant on it. What do you think, Rick? Sorry,
I was
Listy.
going to say, I think, yes, definitely. It's one of the most common things that our patients will report to us. If they've got an inflammatory skin condition, whether it's eczema, whether it's something else, stress is very much a trigger for them. It's not the key driver always, but certainly if you're vulnerable, if you're prone to these sorts of things, definitely have stressful life events can trigger flares. And wider stress as well, I would say, concurrent infection, whatever, that sort of thing can also play a role. Would you agree?
Yeah, I think the interface between stress and inflammatory skin problems, or specifically eczema, is quite complicated. And I think generally people do seem to get worse when they're stressed, but I think it's not really fully understood why. Whether is there a direct mechanism, of being stressed that exacerbates the immune system, or is it also other factors just in the way that you experience your condition, or the way you actually go about managing your condition, or your behavior like itching and rubbing, which can all change and as Felicity alluded to, may not cause the condition, but could exacerbate and further lead to a flare of the condition. So I think broadly speaking, often when patients are stressed, their condition gets worse, but whether the stress is directly causing that is actually quite nuanced and complicated.
Difficult to tease out. I've had another question from somebody who's developed fissuring of the hands and the feet around menopause. What's the feeling about hormonal changes associated with the menopause? Is this something that we see commonly, triggering hand eczema where there perhaps hasn't been any before?
So I would say this is an under-examined area in dermatology, or in medicine generally. Menopausal changes on the skin and the body, but it is common for women clinically to report to me that they notice cyclical flaring if they're active menarche, and then perimenopause can often be a trigger for many women in terms of their skin. And then we know postmenopausally our skin does become naturally drier, and then you are more prone to potentially being driving an eczema flare up, whether that be on the hands or elsewhere on the body. So it definitely does play a role, I think, and I think we don't know enough about it.
Yeah, so definitely an additional risk factor.
It's slightly deviating away from menopause and building on, but as your skin ages, and Felicity just touched on it, it does naturally dry out. So, you'll know, Gemma, as well, that there are specific types of eczemas that we see in older people that is related to drier skin, particularly on the lower limbs, like around the legs and ankles. So that can also, so the barrier function and the dryness or the inability for the skin to itself stay moisturized is quite a big factor with some of these inflammatory skin problems.
And I think also thinking about, the skin can change as well in pregnancy, particularly postnatally, but also it's new mothers and fathers as well, I should say. When you have a new baby, you're constantly washing your hands a lot more and cleansing a lot more. And quite often, people who are atopic, sometimes hand eczema can develop when they become parents for the first time as well, often driven by irritation. So that's another sort of slightly connected thing as well.
Yeah, absolutely. Good. There's another question, and I think this is another really practical one, which is it's all very well having your creams and things that you're using at home, but clearly we have to go out of the home. We might be using public toilets and things, and it's very difficult when you're exposed to the sort of soaps and things that you get there. And during the pandemic, we all saw it with the amount of hand sanitizing gels that we use. Any top tips for how you manage your hand eczema when you're out and about and trying to just live your life? I know, Julie, just come to you.
It's really tricky. But I think a very simple solution is, and it's a little bit of a pain, but I would say decant the emollient you use and the emollient that you use that suits you. You may use a different one for washing, but normally a normal emollient, whether it's a cream gel, you can use for washing as well as moisturizing, hopefully the same one. We don't tend to prescribe hand washes or bath oils anymore because the key is that you use the emollient that suits you as your soap substitute, but actually just buying those little containers, little travel pots, and literally just putting your own emollient in that, taking it out and about with you. And when you are in a public place, really trying to resist that temptation to use those harsh soaps, particularly in public lavatories, because they're going to be the harshest type of detergent, and you'll find yourself, going 3 steps back. So just, when you pack your bag and you're taking out your keys and your phones, just put in a little pot of your emollient you use and try and use that for hand washing when you're out and about.
Very good advice indeed. I think we've probably just got time for one more question before we bring the session to an end. So I'm going to go to this one. So could mobile phones or cases or a computer mouse cause hand eczema? This person just has eczema on their right hand, so I'm assuming they're right-handed and are handling those items.
I think that's one for me. So possibly. There are reported cases of people with metal contact allergy from their phone screens and from rubber accelerator or silicone contact allergy from certain cases on phones. Mice we see far less frequently. They're generally pretty hard plastic and inert, so it's rare for that. We have had occasionally people with wrist dermatitis, from rubber, from their pads they've been using at their keypad. So it's one worth thinking about for sure, but it sort of depends on what it is that you're using.
Okay, brilliant. Thank you. Great. So I think with the time at 3 minutes to 7, we ought to probably draw it to a close. So the first thing I want to do is to give a really big thank you to Felicity, to Rick, and for Julie for being such fabulous speakers and panelists answering all those questions. A big thank you to you for tuning in and listening and for providing so many great stimulating questions for our panel to answer. I hope you've enjoyed it. For more information about hand eczema, as we've mentioned before, please visit the National Eczema Society website, eczema.org. This is the QR code for feedback. This is really helpful. It helps tell us how we did today, what you enjoyed, what you'd like to see more of, and possible topics for future webinars in conjunction between St John's Derm Academy and the National Eczema Society. And if you'd like to support the very valuable work that the National Eczema Society do, this is another QR code, so please do donate if you would like to help support their very valuable work. As I said before, we'll post an email out to everybody to get further feedback if you don't want to do the QR code, and that's really helpful for us. So we really hope we see you again at future patient and public events in collaboration with the National Eczema Society. Thank you, everybody, and good night.